So, good morning, everybody. Good morning, everybody. You're welcome. My name is David Serrada from Makerere University, and we are about to start a very exciting session, the HPTN Scholars Plenary. This is prime time. But I'll give you a very quick history, for some who are new or who are new to the network, what the HPTN Scholar Program is. The HPTN Scholar Program started in 2010, and its objective is really to develop the next generation of scholars from underrepresented and racial or ethnic minorities. Much of our studies are really towards these populations, so we feel that we should develop a next generation of scholars. In 2010, we started with a domestic program, and in 2015, the international program was added on. Up to now, we have had 73 scholars who have gone through this program. The program leadership, I'd like to introduce them here. I'm one of them, but Stan Vermont, and Del Wheeler, where's Del Wheeler? There you are. And Croatia is not able to come, but we are the 4 people who really drive this. Eble with the Secretariat, Shelley Johnson, is Shelley in the audience? Along with Gabrielle. So we would like to think that by many measures, this program has been very successful, given that if you track the past scholars, where they are, the kind of publications they've been able to get and the awards, we are very proud of what has been achieved. Okay, with that, we would like to start the presentation. We have 4 presentations, and we shall start with the first presentation, association between support intervention and adherence to HIV pre-exposure prophylaxis among young African women. And this study is from HPTN 08 dataset. And it will be presented by Dr. Abubakar Syed. Sorry if I didn't pronounce that well. So Abubakar really is a scientist with Massachusetts General Hospital. He's a PhD in pharmacy, and he has his interest in particularly in developing an implementation of pharmacy-based intervention to reduce healthcare disparity. And we look forward to his presentation. Abubakar, you have the floor.
So good morning, everybody, and it is a great pleasure and honors to be here today to present my project entitled The Association Between Use of Adherence Support Interventions and Adherence to HIV Pre-Exposure Prophylaxis Among Young African Women. A little background, adolescent girls and young women in sub-Saharan Africa continue to be at high risk of contracting HIV, and this subpopulation constitute approximately 77% of new infections in their age range in the year 2022. And adherence to PrEP is a known challenge among these subpopulations. Here in our project, we use group-based trajectory modeling as a novel methodological approach used to analyze trajectories of an outcome of interest over time. No previous study has been conducted to characterize the trajectories of an objective measures of adherence and adherence support interventions and identify the association between them. We believe that characterization of these trajectories improve or help in customizing targeted interventions to improve adherence and to estimate the exposures for adherence support interventions. HPTN 82 was conducted in 2026-2018 to evaluate the daily dose of PrEP as a primary prevention strategy among African women in South Africa and in Zimbabwe. And it includes uninfected women aged 16 to 25 years who are sexually active and with voice risk scores. Voice risk scores risk 5 and above and interested in PrEP and have access to mobile phone and hepatitis B seronegatives. 400 accepted PrEP at enrollment were randomized to either standard adherence support plus drug level feedbacks or adherence support interventions. The adherence support interventions include weekly two-way SMS message in the first 3 months and optional adherence clubs with brief counseling and discrete pill containers. The aim of the project was to determine the association between trajectory of response to weekly two SMS message and high tenofovir diphosphate level at 3 months of follow-up as an early indicators of adherence to PrEP, and to assess the associations between trajectories of tenofovir level and trajectories of participation in peer support adherence clubs during the follow-up period. Group-based trajectory modeling was used to identify the trajectories of participations in monthly peer support adherence clubs and intracellular tenofovir diphosphate levels using sensor normal finite mixture models and two-way SMS using allogic models. And the chi-square test was used to compare baseline variable between the identified trajectories of tenofovir diphosphate and to determine the association between high PrEP adherence and response to SMS trajectories and the association between tenofovir diphosphate level and trajectory of participation in support adherence clubs. We use this data for the analysis, and this data plugin was used to estimate group-based trajectory modeling parameters. The results show that 2/3 aged 20 years and above, and the majority had a secondary level of education, and had a primary sex partner during the previous months, and half of them reported using a condom during vaginal sex. The median voice risk score was 7, and 2/3 perceive themselves not to be at risk of HIV in the next year. Of the participants retained in the study, nearly 1/4 attained high concentrations of tenofovir diphosphate level at 3 months, which decreased to 20.9 at 6 months and approximately 9 at 12 months. Group-based trajectory modeling shows that there are 2 trajectories. 1/3 of the participants follows the consistently low trajectories, and 1/3 follows the high decreasing trajectories, which start at 900 that drop to 500 at the end of the follow-up. The result also shows that for the participant aged 20 years and above, they are significantly high proportion of them were grouped in the high decreasing trajectories of tenofovir diphosphate levels. And also we observed that for the participants who consider themselves or perceive themselves not at risk at all, approximately 56 has been grouped in the consistently low group compared to 38.3 in the high decreasing groups. Also, group-based trajectory modeling show that there are 2 categories of, or 2 groups of consistently moderate participation in adherence clubs, and 1/3 or slightly increasing trajectories. There are 3 groups also of respond to SMS message, consistently high, constitute 6% approximately, and 30% with moderate decreasing response, and 7% with consistently low response. We observed that 77.4% of the participants who are grouped in the high decreasing trajectories of tenofovir levels were from the category of consistently moderate participation in adherence clubs. And also there, 80% of the participants who had high concentrations at 3 months were from the group of trajectory who responds highly to SMS message. Adherence to PrEP was a challenge among South African and Zimbabwean young girls in this demonstration project, and based on tenofovir diphosphate level, 1/3 has high initial adherence, which decreased over 12 months, and approximately 2/3 participants had consistently low adherence. Adolescents, a girl and young women who are adherents to attending support clubs and responding to SMS are also adherents to PrEP. The dose-response relationship with response to the weekly 2 SMS message warrant further investigation to determine long-term effect on high adherence. Peer support group might be used to support adherence initially and may provide support to this important subpopulation who start with high adherence and motivations. Adherence support strategies should be utilized to provide educations for adolescents, girls, and young women on how to align PrEP use with period of high risk. The strengths of the study is the use of objective measures of intracellular tenofovir diphosphate level as indicators of adherence, and the use of group-based trajectory modeling to delineate trajectories of both the drugs and adherence interventions in order to characterize the association between them. And the limitations that PrEP adherence declines substantially during the follow-up period, which limit the ability to identify the associations between SMS response and monthly adherence supports clubs with longer-term high adherence PrEP. Drug level were measured at 3 points, which limit the potential numbers of identified trajectory of the drugs to 2. In conclusion, PrEP adherence support strategies in the form of two-way SMS message response and participation in peer-led adherence support clubs were used by a majority of the respondents. Oral PrEP remain a major PrEP options available for African adolescents, girls, and young women, and additional research is needed to support on adherence support strategy to improve PrEP adherence. In parallel with increased access to long-acting pre-exposure prophylaxis formulations. The presentation highlights the question, is there an association between use of adherence support intervention and adherence to HIV pre-exposure prophylaxis among adolescents, girls, and young African women? And the key finding that high participation in adherence support clubs and two-way SMS message was associated with high level of adherence to PrEP. The implication that the provision of acceptable PrEP adherence support strategies in the form of two-way SMS message and peer adherence support clubs could improve PrEP adherence and prevention effectiveness. Thank you very much. This is my contributors.
Thank you, Abubakar, finishing on time. Appreciate that. Our next speaker is going to talk on stigma and sexually transmitted diseases among black men having sex with men. This is by Melanie Walcott. Melanie Walcott is an assistant professor in the University of Albany, New York. And she is actually very interested in social structures associated with high-risk behavior. You're most welcome. Thank you.
Good morning, everyone. I am Melanie Walcott, and I'll be talking about stigma and discrimination and sexually transmitted infections among black men who have sex with men who participated in HPTN 061. So although this study has been conducted over 14 years ago, the findings are highly relevant today as the rates of STIs have been increasing in the US over the past recent years. So some of you may have seen headlines such as this, where CDC is highlighting that STIs must be considered a public health priority, as well as this, where CDC is acknowledging that the rates of STIs are out of control. So even though STIs have been known to be associated with increased morbidity rates and cost the U.S. approximately $2 billion each year, we haven't taken these groups of infections seriously. Until now, the rates are so high, we are forced to act. And as of 2020 December, we now have our first national STI strategic plan, and we also have our first federal STI implementation plan. And if you could note here, the plan recognizes that STI is a threat to the health of Americans, so finally some respect for STIs. And the plan also lays out a clear vision for preventing STIs in the US, as well as aims to ensure that all Americans will have access to STI prevention and treatment services that is free of stigma and discrimination. So we all know that Black MSM are disproportionately affected by STIs, and we know that some STIs increases HIV acquisition as well as transmission. And we know that Black MSM have the highest rates of HIV infection in the US, so you could understand the magnitude of this problem and the importance of addressing it. Stigma has been shown to be a formidable barrier for engaging in HIV and STI prevention and treatment services, which could further exacerbate rates of STIs as well as HIV among Black men who have sex with men. Stigma has been shown to influence sexual risk behaviors that increases vulnerability for HIV acquisition, including pathways such as it negatively affects self-concept as well as self-esteem, increases depression. It also influences testing practices as well as partner notification and treatment. Importantly also, it could reduce the likelihood of MSM disclosing same-sex relationship to providers, thereby impairing providers' ability to care effectively for this population. So therefore, it's important for us to understand the ways in which stigma affects Black MSM, a highly stigmatized population, and the mechanism in which it might do so. This will help us to better develop interventions and programs that could help us to treat MSM more effectively and reduces the burden of both STIs and HIV. So the purpose of this study was to assess the association between stigmas and STIs. STIs being used here as a marker for sexual risk behaviors. And then we also wanted to examine this association over time, as well as assess the ways in which multiple types of stigma influence STIs. So we used secondary data from HPTN 061, which was designed to assess a multi-component, the feasibility of a multi-component intervention to reduce incidence of HIV among Black MSM. The study was conducted in 2009 to 2011, and it included 6 sites. Participants were recruited directly from the community as well as referrals from their sexual networks. So the response rate, or the retention rate for this study at month 6 was 80%, and month 12 was 75%. For our study, we focused on 5 different types of stigma: perceived racism, sexual discrimination, perceived HIV stigma, internalized homophobia, and healthcare-related discrimination. The outcome was any STIs, be it chlamydia, syphilis, or gonorrhea. We used descriptive statistics to characterize the sample. Multivariate logistic regression were used to assess the association between stigmas and STIs at baseline, and we used generalized estimating equation to examine this association over time. All the models adjusted for covariates that were shown to be associated with the outcome. And of course, we used SAS to analyze the data. So overall, we had 1,518 MSM in this study. We excluded individuals who identified as transgender, which is about 30 participants or so. Over 70% of the participants reported earning less than $30,000 annually. Over 50% reported that their highest level of education was high school or less. 16.6% were given an STI diagnosis, while 10.7% an HIV diagnosis. 88% of the participants reported condomless sex, anal sex, in the past 6 months. The most commonly reported stigma was racial discrimination, while the least common was healthcare-related stigma, and 68% of the participants reported 2 or more stigmas. So for AIM-1, we generated a model that included all the variables that had a p-value of 0.05 or less in the univariate analysis. And then we added all the stigma variables because we wanted to see the added effect of these stigma, different types of stigma. And here you could see that high sexual discrimination as well as perceived HIV stigma was associated with increased odds of being given an STI diagnosis, whereas healthcare-related stigma and high racism and experience of high racism was associated with reduced odds. This was an unexpected finding, and we'll talk a little bit more about that in the discussion. So for AIM-2, we created separate stigma models. So this is showing the healthcare-related stigma model, and we're showing that healthcare-related stigma was associated with reduced odds of being given an STI diagnosis. And this association was marginally significant at month 6, but lost significance at 12 years. For all the other stigma variables, we did not find any association at baseline or over the follow-up period. For AIM-3, we calculated a separate stigma variable comparing individuals who experience 0 to 1 stigma, 2 to 3, or 3 to 4. And here we're seeing that individuals who experience 2 to 3 stigmas compared to those who experience 0 to 1, there was reduced odds of being given an STI diagnosis. Again, another unexpected finding. So the reduced odds of healthcare-related discrimination as well as racism and experiencing multiple stigma, that association with STIs where we're seeing a reduced odds. This is unusual, unexpected, but based on qualitative work on other studies involving Black MSM, participants share that experiences of stigma motivates them to be highly engaged in their care. This was not among all MSM, but those who were well supported had great networks. So perhaps this could be explaining. I'd love to hear your thoughts during the discussion, the question and answer session. And the fact that the association did not hold throughout the follow-up analysis, this could be the fact that we did not adjust for intervention effects. We plan to do this in further analysis. We are still teasing out the ways in which this variable was measured. So these findings must be taken into consideration. The limitations of this study, self-reported data. We primarily included low-income MSM, as well as we only included 6 cities. The study was conducted over 14 years ago. So much has changed in terms of the sexual landscape and how we think about, how we measure stigma, and what we understand of stigma. So in closing, it has been over 14 years since HPTN 061, yet the HIV STI narrative among Black MSM remains the same. So the question for us is, what else could we do differently so the next 5 years, the next 10 years, we will change this narrative? Certainly more research is needed to understand the ways in which these different types of stigma influence sexual behaviors, uptake of HIV prevention and treatment services, as well as STI outcomes. I think the need for more intervention study to keep abreast with the great work that you have been doing. You have done such a great job with advancing biomedical, HIV biomedical and prevention and treatment approaches, but unless individuals are changing their behaviors, then we will not see the benefit. I certainly believe it's condom use and safer sex, partner reduction, should be central for any prevention and treatment program. We have to still continue to push that message. And we also need to create more opportunities to work, to learn from MSM. It would be nice to have a forum here, which is led by MSM, highly sexually active MSM, sex workers, different experiences so we could learn. I learned about so many things from study participants. It really will be to continue to grow and to have more opportunities to learn from them. So thank you so much. I'd like to thank my mentors and everyone who supported this work. Thank you.
On time. The next presenter is Fiona Semambo. Fiona Semambo is going to present on correlates of long-acting reversible contraceptive use among young women in Southern Africa. Fiona is a public health physician working with Makerere University, Johns Hopkins University. And she is very much interested in evaluating various HIV prevention modalities, particularly as they affect adolescent and young women, to promote sexual and reproductive health. You're most welcome. Eric, the timer doesn't work. Is there anything we can do about the timer? Thank you. It's getting my presenter nervous.
Okay, thank you, Professor Serada, for that kind introduction. And thanks to the organizers for giving me the opportunity to discuss correlates of long-acting reversible contraceptive use among young women in Southern Africa. And this is a secondary analysis from HPTN 082. So I'll begin with the key highlights. We know that overall utilization of LAC in sub-Saharan Africa is low, estimated at 0.3%, and acceptance is less among women below 35 years. And this includes the adolescent girls and young women. So understanding the predictors of LAC use among the adolescents is very critical. The key findings from this analysis show that in the HPTN 082 cohort, 60% of adolescent girls and young women opted for LAC method, and prior pregnancy and comfort talking to close friends about sexual relationships was significantly associated with choosing a LAC method. In addition to that, LAC use was associated with condomless sex. Therefore, in the context of HIV prevention, integration of HIV prevention within the sexual and reproductive health services is key for this population in sub-Saharan Africa. And continued efforts to develop LAC-based MPTs is recommended, especially in the context of inconsistent condom use. So this is just a brief slide on the timelines from the time I received this award to where we are now. And what I'm left with now is to submit an abstract for presentation at a conference, as well as submit a manuscript before the end of the program in November. So a bit about the background. IUCDs, injectables, and implants are classified as LACs, and they have the advantages of being safe, more effective, having higher user acceptability, fewer side effects, minimal partner involvement, lower discontinuation rates. They don't need user adherence, and hence they have a decreased risk of incorrect and inconsistent use, which is common to young contraceptive users. Now, we know that the prevalence of adolescent pregnancies is high. WHO estimated it to be at approximately 21 million as of 2019. And therefore, the use of LACs would play an important role in preventing these unintended pregnancies. Despite this, LAC uptake by this population remains low and inconsistent. And the rationale is that contraceptive use is one of the main components in the reproductive health of women, and also it's a strategy for PMTCT, because when you prevent adolescent pregnancy, then you will prevent the poor maternal and infant outcomes, which would predispose to mother-to-child transmission. There's still an unmet need for effective family planning, and UNFPA estimated this to be at 23% among these adolescent girls. So if we improve LAC use, we would be able to provide comprehensive and tailor-made sexual and reproductive health services in this population. Therefore, it's important for us to understand the factors associated with LAC uptake and continuation, which may give us insights into the benefits and challenges that they face. So this is an analysis from HPTN 082, which was designed to evaluate the uptake and adherence to daily oral PrEP as a primary prevention strategy for young African women. The study population consists of 451 HIV negative, 16 to 25-year-old non-pregnant women who had vaginal or anal sex in the month preceding screening and reported interest in taking PrEP. It was conducted in Southern Africa between October 2016 and 2018, and visits occurred at months 1, 2, 3, 6, 9, and 12. And during the visits, HIV testing and pregnancy testing were done. Contraceptive counseling occurred throughout the study visits till week 39, and women had the option to initiate, decline, switch, or even not to be on a contraceptive method. So there were 3 aims for my study. I aimed to evaluate the correlates of LAC use among young women in Southern Africa enrolled in the HPTN study over the 39-week follow-up period, and to describe the frequency and patterns of contraceptive switch, as well as determine LAC use at enrollment, whether LAC use at enrollment was associated with condom-less vaginal sex during the 52-week follow-up period. And the analysis included all women who were enrolled in the study and initiated contraceptives. Therefore, those who didn't use contraceptive use at all during the study were excluded from the analysis. We used descriptive statistics to summarize the data and logistic regression to determine factors associated with the LAC use. Okay, so I'll delve into the results, briefly about the descriptive characteristics. Among those who used LAC, we see that 7% were aged between 16 to 17, 55.5% were aged between 18 to 21 years, and 37.5% were aged between 22 and 26. And looking at the level of education, among the LAC users, 2.7 attained a primary education, 86.3 had attained a secondary education, and 11% had attained university education. Then looking into the demographics and behavioral characteristics, among the LAC users, at least 63% had one partner, and about 36% had more than 2 partners. And looking at the age of their primary partners, 53% were within 5 years, and 2.1% had a partner who was younger, and 44% had a partner who was older. And significantly, for those who had been pregnant before, 61.1%, among the LAC users, 61.1% had been pregnant before. So looking at the results of AIM 1, significantly, we see that those who are comfortable talking to close friends about sexual relationships had a higher likelihood of using LAC, as well as those who had ever been pregnant, with a p-value of less than 0.001. This slide is busy and I'm not able to point, but basically what it shows is that there was minimal switching in this study, as there was, when you look at the highly effective LA, where you see HELA, where it says N is equal to 299, those are the ones who used LAC. And so when you follow through the visits from baseline, we see that most of them actually stayed on LAC. There were a few switches in this study. So this is AIM 3, looking at condomless vaginal sex. We see that those who were always using condoms had a 73% less likelihood of using LAC. So in this cohort of young women, LAC use is associated with talking to friends about sexual relationships, condomless vaginal sex, and having had a previous pregnancy. Peer support plays an important role in decision-making for adolescent girls, and this was seen in prior studies. And then regarding prior pregnancy, this could be explained by the fact that women usually have an unplanned pregnancy, especially the adolescents, and this engages them in the health service, which would lead to them choosing a contraceptive to avoid another pregnancy. And the fact that those who were on luck were less likely to use a condom during vaginal sex would mean that alternative forms of HIV prevention like PrEP still need to be accessible to them, which calls for the need for integration of HIV and sexual and reproductive health services. So the implications for the future, integration of HIV and sexual and reproductive health services into existing primary healthcare services remains a key service delivery model to implement comprehensive, complementary HIV and sexual and reproductive services for this population, and MPTs may be a game changer for the prevention of HIV and pregnancies for adolescent girls and young women. I would like to acknowledge my mentor, who's not present here today, Professor Jennifer Velosa, Dr. Brenda Gatti, Dr. Clemencia Nakavito, and the statistician, Michael, who is also not present today. And I would also like to acknowledge my co-mentors, Professor Connie Kayla, Professor Schneid, as well as Professor Deborah Donnell and Githa. I acknowledge the HPTN 082 study participants, the module site leadership, the funders of the HPTN, the administrators, Sherry and Gabby, as well as the scholar leadership for giving me this life-changing opportunity. Thank you.
Thank you very much. All my scholars keep time. So last but not least is you're going to hear about substance use and self-rated health among women at risk of HIV acquisition by Dr. Olatukumbo Osibogu. She is a public health physician. She's an assistant professor in epidemiology in the University of Florida International. And her main interests are really revolve around use of and cigarettes, substance use, cardiovascular health promotion, and women in health, so non-communicable diseases. You're most welcome.
Thank you. Good morning, everyone. Thank you for being here to listen to my presentation. I'll be talking about substance use and self-rated health among women at risk of HIV acquisition using the HPTN 04 data. Imagine asking someone a single question to get a good idea about their overall health. That's the power of self-rated health. It's a quick and inexpensive way to assess someone's perception of their overall health. In the United States, in 2019, 11% of adults rated their health as fair or poor. This rate was higher among older adults, Black African American, and those living below 100% of the poverty level. The rate was similar for both adult males and females. Researchers showed a strong association between poor self-rated health and lower SES, Black, older age, women, and even objective markers of health, such as elevated inflammatory biomarkers. The figure on the left shows us the new HIV diagnosis that was made in the US in 2021. Although most new HIV diagnoses were among men, a significant portion was also among women in 2021. 15% of new HIV diagnoses were women, translating to over 5,200 diagnoses. There's some good news here. The proportion of new HIV diagnoses among women has decreased, which dropped from 19% in 2018 to 15% in 2021, which indicates that prevention efforts are indeed working. However, there's still some work to be done, because this slide shows us that there is a significant racial disparity in HIV diagnoses among women. In 2021, Black African American women accounted for a high 61% of the new HIV diagnoses made in women. This is nearly 4 times the percentage of white women and more than double the percentage of Hispanic Latina women. Also, in 2021, the substance use epidemic remained a significant public health issue, with over 27 million adult women reporting illicit drug use in the prior 12 months. Even now, the problem still exists. We know substance use is a public health issue, especially with many women reporting illicit drug use. However, there's a gap in our understanding of the relationship between substance use and self-rated health among women at risk of HIV acquisition, especially for those living in extreme poverty areas. This analysis is exploring factors that mediate the association between substance use and self-rated health among women at risk of HIV acquisition. The goal is to help improve health promotion strategies and interventions. By understanding these connections, we hope that we can help improve this promotion and intervention strategies. This analysis involved the use of HPTN 064 data, a longitudinal cohort study of HIV incidence among women at risk of acquiring HIV in 10 geographic US locations with high HIV rates and poverty. Approximately 2,100 participants aged 18 to 44 years were recruited from May 2009 to July 2010 and followed for 6 months and 12 months, with a retention of 93% and 94% respectively. 88% of the participants were Black and 12% were Hispanic Latina. It's important to highlight that 35% of these women reported using any illicit substances in the prior 6 months, and over 22% reported use frequently. I am sure some of you are wondering why the use of this 2010 data, which is over 14 years now. This is because our analysis is focusing on self-rated health, a measure that is unlikely to be affected by secular trends in HIV prevention advances. So for my project, my aim was to examine the association between substance use and suboptimal self-rated health, and whether mental health conditions mediate this relationship. The hypothesis was that substance use would lead to suboptimal self-rated health, and the relationship is partially mediated by mental health conditions, such as depressive symptoms, and figure shows the direction of the relationship. I used secondary data analysis from baseline and longitudinal data from 2,099 women at risk of HIV acquisition from the HPTN 064 data, as I earlier mentioned. The independent variable was substance use prior 6 months, which included alcohol, which is binge drinking, opioids, cocaine, amphetamine-type stimulants, inhalants, sedatives, sleeping pills, and hallucinogens. We categorized the frequency of the primary drug used by the participants as non-user, non-frequent user, or frequent user. Additionally, we considered the total number of substances used as a continuous variable. The dependent variable was self-rated health, and participants were asked about their perception of health, rated on a 5-point Likert scale, from excellent to poor. For analysis, we categorized excellent, very good, and good as optimal health, and suboptimal health as fair or poor. For our mediators, we looked at 2 mental health conditions, depressive symptoms and PTSD symptoms. Depressive symptoms were assessed using the CESD scale, a validated 8-item question, and having 7 or more was categorized as having depressive symptoms, while the PTSD symptoms were assessed using the primary care PTSD scale. Was a 4-item question, and having 3 or more was categorized as someone having symptoms of PTSD. We had covariates such as individual factors, ranging from demographic, socioeconomic factors, and health-related behaviors, and social factors such as partner, incarceration, social support, and violence. For our analysis plan, we conducted descriptive statistics, bivariate analysis, and regression analysis, and we also conducted a causal mediation analysis. For the supplemental analysis, we want to examine the change in substance use and its association with change in self-rated health. and also do an additional analysis looking at opioid use versus non-opioid use and its association with self-rated health. However, I will not be discussing the results of the last two in the presentation today. From our analysis, we found that among 2057 participants, nearly 38% reported frequent substance use, and 16% reported suboptimal self-rated health at baseline. When we compared groups, we found that frequent substance users tended to be older adults, aged 35 or more, of Hispanic ethnicity, and have less than a high school education. They also had no health insurance, had unstable housing, and were more likely to report symptoms of depression and PTSD. This table is showing the results from the regression analysis for the association between substance use and suboptimal self-rated health at baseline 6 months and 12 months. In the adjusted regression analysis, we found that non-frequent and frequent substance use were associated with higher odds of reporting suboptimal self-rated health at baseline and at 6 months compared to a non-user. However, it's important to note that these associations were not statistically significant. When we look at the number of substances used at the top half of this table, we also see a similar association. For the mediation analysis, we found that depressive symptoms partially mediated the association between substance use and suboptimal self-rated health at baseline. For frequent users, depressive symptoms accounted for 54% of the total effect of substance use on suboptimal self-rated health. We found no effect for PTSD symptoms on the association. While the direct association between frequent substance use and suboptimal self-rated health was not statistically significant, this study revealed an important finding. Depressive symptoms partially mediated the association, accounting for over 50% of the total effect of substance use on suboptimal self-rated health. It's important to note that PTSD symptoms did not mediate the association between substance use and self-rated health in this particular study population. This slide is just to show us what the literature is saying about the relationship between substance use and self-rated health mediated through depressive symptoms. It suggests that there's an interplay between these three factors and that it's complex and multifaceted. What we say is that for biological pathways, substance use can alter the brain chemistry, affecting neurotransmitter levels and brain functioning, and this can lead to mood dysregulation, potentially exacerbating depressive symptoms. And when we look at the physiological pathways, we can see that substance use often coexists with psychological distress, and people may often use substances for mood regulation, and which can often worsen depressive symptoms and lead to poorer self-rated health perceptions. And then when we look at the social context, the literature suggests that limited social networks worsen depressive symptoms and negatively impacts self-rated health. And then also looking at L behavioral patterns, substance use may increase high sexual risk behaviors such as unprotected sex and having multiple sexual partners. And this can increase the likelihood of HIV acquisition and thereby also impairing overall health. So what are the implications of my study findings and future considerations? Importantly, our study found that frequent substance use was associated with poor self-rated health, and depressive symptoms appears to be a major factor. This underscores the critical need for integrated care services that address both substance use and mental health challenges. By providing comprehensive support, we can empower these women to improve their personal health and potentially reduce the risk of HIV acquisition. Additionally, longitudinal studies may provide further understanding of the causal relationships between substance use and poorer self-rated health. Does substance use actually lead to poorer self-rated health, or does poorer self-rated health lead to substance use? These are questions that we can potentially answer. So what I have told you today in my presentation is that the analysis assessed the association between substance use and suboptimal self-rated health, and whether mental health conditions explain this relationship. Frequent substance use showed a positive association between suboptimal self-rated health, with depressive symptoms partially mediating this association. This research highlights the role of depressive symptoms in the pathway between substance use and suboptimal self-rated health for women at risk of HIV. Moving beyond these study findings, addressing both substance use and mental health may promote optimal self-rated health, which may potentially reduce HIV risk in these women. I'd like to thank my mentors, Dr. Jessica Justman and Dr. Irene Cole. Unfortunately, Dr. Irene Cole was unable to attend today. I'd also like to thank Devang Agrawat, my statistical research associate. Thank you, this is my contact.
Thank you. Thank you very much for the scholars once again. Before I open this up for questions and answers, out from the scholar leadership, I would like to thank all the mentors who actually mentor these scholars for their time and effort, the back and forth. This program cannot succeed without the mentorship. Many of you are in this room, so we really, really thank you for your time and effort in mentoring these young scholars. And I would also like to give a special thanks once again, I will not apologize for this, for Shirley Johnson and Gabriela Salina for the secretariat. They manage the secretariat. They keep us on our toes and on our hooks. So they really do a great job of really running the show. We thank you. And also for the Data Management Center, SHARP, Deborah and the group. They are the ones who provide all the statistical help for these scholars. We really, really thank you for that. I would like to call, you can see the data sets they're using, HPTN 082, HPTN 061. I would like to call for the investigators, the committees, to really avail the data. They no longer, after they have done their primary and secondary outcomes, so that we can have these young career scientists use these data sets, be able to squeeze out a little bit more juice. All right, we open to questions. You could ask these smart, young, dynamic scholars any question. We have some time, and don't run away. I've been told lunch is not yet ready. So we're open to questions.
Hi. Middle.
Yes. Oh. Yes, Jessica.
Thank you very much. Great session. My question is for our first presenter, Dr. Saeed. I really took, my ears perked up when you described how 2/3 of the young women that you analyzed rated themselves as at low risk, right? Their perception of risk was low, and that was for 2/3. I wondered if you analyzed the trajectories, the trajectory modeling based on this self-rated risk perception, since you had 2/3 low and presumably 1/3 is high. Did that influence adherence, either based on drug levels or participation in the peer support groups and responses to SMS?
Thank you very much, Prof. Jessica. Thank you very much, Prof. Jessica, for the questions. And actually, I did this, but I did not observe some sort of variations. This tool has been, this variable has been assessed.
All right, speak a little bit near to the mic.
Okay, so I said that I have already this analysis just a preliminary analysis to show if there is a variation between what they have already reported in the baseline compared to 3 other visits during the follow-up. But actually, there is no some sort of variation in proportions of reporting that they are not at all at high risk or small counts or high counts.
All right. Yes, sir.
Hi, Ken, University of Pittsburgh. Wanted to ask a question to Dr. Walcott. Great presentation, and I thought the finding regarding the experience of healthcare discrimination and sexual discrimination having opposite associations was really interesting. I was wondering if you could speak more to how you defined and captured that and whether or not you think the two might overlap some.
Could you repeat between healthcare discrimination and?
And sexual discrimination.
So thank you for your question. And of course, my contributor slide was missing. So I want a big thank you to my team of mentors, Dr. Brian too, as well as the statistician who really helped with this work, Miriam Warso and Dr. Scalland who provided support. So to answer your question, these were self-reported measures. A scale was used to measure these different types of stigma. And of course, we had categories low, never happened, or medium and high. So this is how we assessed. We are still trying to see what else might explain this association. It is unusual, but like I mentioned, we learned from qualitative studies where when participants do experience stigma, it put them in this state of being hypervigilant and being more engaged in their care than they normally would. And perhaps this might in part explain this association that we're seeing that we totally were not expecting.
And I guess part of it is maybe just from my own education, when we think about healthcare stigma, I feel like if somebody's experience, can someone who experience sexual stigma that is also healthcare stigma is sort of at the crux?
I'm not quite sure how to answer to this question. So there are two separate scales used, and perhaps part of it is there are 2 items used to measure healthcare-related stigma or healthcare-related discrimination or unfair treatment while accessing care. And it was you or any member of your family experience or friends experience unfair treatment while accessing care, and then was this you? So this is another limitation which I should have highlighted with the study. The question that determined that yes, it was self, I experienced stigma, because of low numbers, the models were unstable, so we had to use the 1 item. So that is another limitation that could be experienced in this. But in terms of experience of sex-related discrimination, so there are a number of questions that were asked in terms of were you ignored, and was this because of do you think this was because of your sex, and to what extent were you bothered by it, or did it happen to you at all? I hope that answers your question.
Thank you.
Okay.
Yes, please.
Hi, Daniel Driffin, HPTN. This question also is for Dr. Walcott. I think it was really, really interesting, especially using the 061 data. I'm wondering, were you able to see if there were any differences across those 2 stigma assessments, thinking of the different cities? So comparing it Atlanta or to LA, San Francisco, Boston, and such.
Yeah, thanks for the question. That assessment was not done, but certainly now that it's something worth looking at. We're looking at overall what was the experience. But we didn't stratify by city.
In part 2, do you know if the same measures were asked in subsequent studies like 073 or 078 amongst the Black MSM who were enrolled?
No, I am not sure. No.
Some more. Okay, thank you.
Good afternoon. Thank you for the presentation. So I have 2 questions for the last speaker. So the first one is, how does the intersection of mental health challenges and societal stigmatization affect the HIV risk and prevention behaviors amongst women? And then secondly, what are the specific barriers faced by women at risk of HIV in accessing mental health support, and how do these barriers impact their overall health outcomes? Thank you.
Sorry, can you?
You want the question repeated?
Yes.
Both of them.
Slowly.
The last one.
Both of them, sorry.
Okay,
I'm
so the
trying to
first
write
one
them
is
down.
how does the intersection of mental health challenges and societal stigmatization affect the risk and prevention behaviors amongst women? And then the second question is, what are the specific barriers faced by women at risk of HIV in accessing mental health support, and how do these barriers impact their overall health outcome?
All right.
Yeah, thank you very much for the question. That it's a very important question. And the first question relates to how does the intersection of mental health challenges and societal challenges affect risk, HIV risk acquisition among these women? It's a tricky question in terms of, we know that women that are at risk of health challenges in general are faced with so many factors that affect their health, ranging from mental health symptoms due to their lifestyle behaviors, ranging from depressive symptoms, PTSD, violence, based on their neighborhoods or where they're located. So there's definitely an intersection between mental health and societal challenges, which I'm not able to give a full picture of, because I have to delve into the literature to be able to clearly explain this intersection. But we know that these women are faced with a variety of challenges. And then in terms of the specific barriers that they're faced with, I mentioned in my slides that the literature shows that these women have limited social networks. They have financial insecurity. They have lack of health care insurance. These are barriers that will limit them from accessing treatments. They may also have face barriers to mental health treatment options as well. So these are all barriers that these women have faced with that could affect their health behaviors, ultimately affect their overall health outcomes. I hope that answers your question.
All right. I don't see, Wafa.
Yes, thank you very much. As always, really fantastic presentations and such wonderful work by all of you and your mentors as well. I have a question, and maybe it's a comment for Dr. Saeed. It seems to me that we are still struggling with how do we enhance adherence with oral PrEP, daily oral PrEP overall. And I would imagine that traditionally we haven't really kind of looked, while we're doing these studies, we haven't been looking on an ongoing basis at the data and adjusting our interventions based on those. Like, it seems to me like this is consistent with what we heard of in the last session, which is looking at the biological measures of adherence and also looking at participation in SMS. Somehow it's telling me that maybe we should somehow think that we should be looking at the data and adapting our interventions along the way, rather than just giving kind of one intervention and waiting till the end to see the results. Just wondering what you thought about that. Thank you.
Okay, thank you. Maybe in the last slide, we have recommended or suggested that as we observe that there is high acceptability to this some sort of supportive interventions, I mean the peer review clubs and SMS by these young girls, we propose that this can be utilized for what is called the prevention effective adherence to align the use of PrEP at period of high risk for this. And actually, this is has been proposed by Prof. Jessica Haber in very long papers defining adherence for this concept of preventive adherence, effective adherence, I mean. I think if we align this with the high acceptability of these interventions, it can produce some sort of improvement in adherence But I think it is a complex process and it needs some sort of very cautious and tailored educational message to be posted, for example, as an SMS or delivered to this patient, this PrEP candidate in adherence clubs.
I don't see any hand, but I would like to take the liberty to ask Dr. Osibugu one question. I have asked this question, but I'm sure now you have been reading about it. This issue of self-rated health, how good is it a measure in really predicting people's health, either in the field of infectious disease or in non-communicable diseases?
Yes, thank you for the question. Yes, several research shows that self-rated health is a valuable, a valid and reliable predictor of mortality and health, adverse health outcomes in so many health outcomes in so many different populations. And research shows it severally, and it shows that it's a valid marker of predicting mortality and morbidity in human populations.
Seems very simple to me.
Yes, it's a very simple marker. Once someone tells you that they feel that they have poor health, they actually mean that they have poor health.
All right. I don't see any question online, but any more questions? I know we started a little bit late, and time check is, my time check is 12:25. If there are no more questions, I've been told now lunch is ready. I'd like you once again to give a big clap to these scholars. And thank you very much. Session closed.
Thank you.
I'm sure.